Hello.
Yeah.
My file is still uploading. That is why it's a problem. I do not know. I removed the videos even though it is uploading. Zoom is not, my updates are not happening. Without update, it is not letting me join. I've done a Zoom meeting 4 days back. I do not know what is been happened about this.
Okay. Dear friends, there is some technical glitch, so we may be delayed by a couple of minutes. The moment we are able to upload the PPT, we will start the program. By the way, this is the third year running successfully Cpap. We started in June 2020 under the banner of KCOG, that is Karnataka College of Obstetrics and Gynecology, which is an academic wing of KSOGA. And this is the third year we are into. We have had eminent speakers from the country. We have seen 3 presidents. We started with Dr. Vasaraj Sajjan. Then we moved on to Dr. Kasturi Dhonimat, and now it is Dr. Vidya Tabi who is the president. On behalf of Karnataka Society, Karnataka Association for Obstetrics and Gynecological Societies, KSOGA, I welcome all the delegates to this webinar, which is looked up to every first Thursday. Last Thursday, there was Yuva Kasoga. That's why we postponed it from last Thursday to second Thursday today. And today we have yet another eminent personality. All of you know him very well. He is the man behind a very successful AICOG Kolkata, which was held in January this year. It was a wonderful conference, flawless, I can say a perfect one. And he is not only the president of, he has been the president of West Bengal Obstetrics and Gynecological Society. He is also the chair of Royal College of Indian chapter. So today he is going to talk on bleeding in the first trimester. Once I get his...
Please open my presentation because I can't share.
I have got his PPT and now we can start.
Sir, shall we start, sir?
Yeah, as soon as you can share the presentation, I can start. I'm ready. Please share the presentation. I'm very sorry about this, but
Arun, you may actually now start off the meeting and we will have the CV of Dr. Bhaskar Pal.
Shall we start with the prayer, sir?
Download it, then I will upload the PPT. You give me the host rights.
Shall we start with the prayer, sir? Hello, sir.
Yes, sir.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः
Once again, good evening, dear friends. Thank you for logging into today's webinar under the series of Cpap of Karnataka College of Obstetrics and Gynecology. Arun, can you please put up Sir's CV? Yeah. As you all know, Dr. Bhaskar Pal is a senior consultant gynecologist at Apollo Multispecialty Hospital, Kolkata. He is the chair of AICC RCOG, immediate past president of IAGE, Foxy representative to CEFOG 2021-23, chair organizing committee AICOG 2023, which I was talking about, immediate past president of Bengal Obstetrics and Gynecological Society, vice president of Foxy 2017, and I'm sure he will be standing for Foxy president for the next year. Am I right, Dr. Bhaskar?
Yes.
I think you are starting your, your campaign from KCOG, KSOG.
Yeah.
It's a good thing, and I wish you all the best for your,
Thank you.
Election campaigning, and I'm sure you deserve it very much. He's been a clinical examiner for MRCOG Part 3, and he has got many awards to his credit. He's an able leader. The best testimony for that is the way AICOG Kolkata 2023 was conducted. It was flawless, and everybody enjoyed academic feast, the evening social functions, and there was absolutely no problem. So this is the type of leader we all look up to, and we would be very well guided under his leadership. So without wasting much time, because we have already lost some time, I would like to now upload his presentation, and then I would invite Dr. Bhaskar to give his lecture. Dr. Bhaskar, can you see the?
Yes.
PPT?
Yes. Please go to the presentation mode, and the next slide, please.
Yeah. Okay.
Yeah. Next slide, please.
Yeah. So we'll go ahead. Thank you very much.
Yeah. Next slide, please. Yeah.
Yeah.
Good evening, everyone. Thank you, Dr. Muralidhar Pai, Kasoga, and KCOG for inviting me. And I'm really sorry for the technical problem, which is a little beyond my control. So I chose the topic of early pregnancy bleeding, and we will take it as a problem-based approach. In a problem-based approach, we will not only look at early pregnancy bleeding, but the conditions where the bleeding might be a part or bleeding might become a part a little later. So we will look at amenorrhea with vaginal bleeding, amenorrhea with pain, and amenorrhea with pain and vaginal bleeding. And our three important differential diagnoses are miscarriage and its various types, and ectopic pregnancy and molar pregnancy. Can I have it as on the slideshow mode, please? Yeah, next slide, please. So what is very important as in any problem is to start with the history. And the history, what we ask for is we ask for the last menstrual period, the regularity of the cycle, because if the cycles are irregular, then we need to, maybe the gestational age will be slightly different. Whether there's any history of the use of contraceptives, traditional teaching says whether there's any history of oral contraceptives or hormonal contraceptives in the last 6 months, but actually in the last few months. Whether there's any fertility treatment, because in fertility treatment, then we should be calculating from the date of the rupture of follicle or the date of the embryo transfer. And also, whenever there's a fertility treatment like ART, sometimes you have to keep in mind heterotopic pregnancy. In detail, we need to ask about the type of bleeding. When was the onset of the bleeding? What is the duration of the bleeding, the quantity of the bleeding, the nature of the bleeding, and whether it is associated with pain. In pain, we need to ask about the onset of the pain, the nature of the pain, the site of the pain, the duration of the pain, and the intensity of the pain. So any good case starts with a history. And then we move on to examination. In examination, we look at a general condition and vitals. The general condition and vitals are very important because that tells you how much time you have on your hand, whether you have enough time to investigate or is it an emergency where wasting minutes and hours is going to be dangerous. The abdominal palpation is important with regards to looking for tenderness, guarding rigidity, or presence of any lump. We do a speculum examination to look for whether there is any bleeding and whether the os is open or not. If the bleeding is there, then whether the bleeding is coming from inside the uterus or there are any other pathology. Doing a pervaginal examination is not contraindicated in early pregnancy bleeding. And what we do is we do a pervaginal examination to look for adnexal tenderness, whether there's any adnexal mass, whether there's cervical excitation, which means whether she complains of pain when we move the cervix, and also we feel for whether the os is closed or the os is open. Next slide, please. Now, what are the investigations that you do? The first investigation is a urine pregnancy test. Our teachers used to tell us that in order to diagnose ectopic, you need to be ectopic minded, or what that means that you need to have a high index of suspicion. So my teaching is that any patient in the reproductive age group, irrespective of their marital status, irrespective of whatever history they give, if they come with abdominal pain, we need to do a urine pregnancy test. Along with the urine pregnancy test, we need to do the minimum blood test that we need to do is a complete blood count and a blood group and Rh typing. If the urine pregnancy test is positive, then the first investigation of choice would be a transvaginal sonography. A transvaginal sonography can give us a lot of information. It will tell us whether there is an intrauterine pregnancy or not. I think we've lost that. The transvaginal sonography will tell us whether there's an intrauterine pregnancy or not. And if there is an intrauterine pregnancy, yeah, please move on the slides, please. Yeah, next. 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 And the next one. The next one, please. The previous one, please. Yeah, that's right. So the transvaginal sonography, the first thing to look at is whether there is any intrauterine pregnancy. If we have an intrauterine pregnancy, for all practical purposes, in the absence of an IVF, if this IVF has happened, we can rule out that ectopic, because a heterotopic pregnancy is extremely rare. If the TVS is inconclusive, which means we cannot see an intrauterine pregnancy, nor can we see an ectopic pregnancy in the adnexa, that is when we come to the importance of doing a serum beta HCG. We do the first serum beta HCG, and then if it is inconclusive, we'll repeat the serum beta HCG after 48 hours if the patient is stable. Now, the importance of serum beta HCG is that if you're doing a transvaginal sonography and the serum beta HCG is more than 1500, then you should be able to see an intrauterine pregnancy. Some people would say if the machine is not great, then you'll have to possibly up your HCG level to 2000. So that is the discriminatory zone. So which means above 1500 beta HCG or above 2000 beta HCG, if it is an intrauterine pregnancy, you should be able to see it on a transvaginal sonography. If you cannot see it, then there is a chance that you're dealing with an ectopic pregnancy. And that is when you need a beta HCG, again after 48 hours. If the patient is hemodynamically unstable, we do not have the time to do a beta HCG. We need to cross-match blood. We need to do a coagulation profile. And if operation is anticipated, then other relevant investigations, including serology or whatever the hospital will ask for, that is something needs to be done. So there are three kinds of investigations that we do. One is for a diagnosis, one is for giving anesthesia, and one is, say, whatever the hospital demands, like a serology. Next slide, please. Now, what would we be looking for in TVS? In the TVS, we should be looking for the site of the pregnancy. Is it in the uterus or is it in the adnexa? If it is, and we should be looking at the number of pregnancy, we should be looking at the gestational age, we should be looking at the viability of the pregnancy. We must look at the adnexa in detail, even if there's an intrauterine pregnancy, whether we can see an adnexal pathology. We will look at the os. We'll also look at whether there's free fluid in the abdomen. Usually we'll look at the POD. If this patient has been bedbound for quite some time, then we might not find any fluid in the POD, but you might find fluid in the Morrison's pouch, and that is what we need to look at. Now, when the diagnosis is inconclusive and when we do a serial beta ECG 48 hours apart, we talk of how the beta ECG is rising. If we see a rise in beta ECG of at least 66% to doubling, then it is likely to be a viable intrauterine pregnancy, not invariably, because nothing is invariable in medicine. So if the beta ECG rises by 66% to 100%, then it is likely a viable intrauterine pregnancy. If it is increasing, but it is less than 65% rise, then it is either an ectopic pregnancy or a failing intrauterine pregnancy. If it is falling, then it is a non-viable or failing pregnancy that may be in the uterus, that may be in the adnexa. Doing a serum progesterone is of not much practical help. Next slide, please. Now, if the TVS shows that it is a molar pregnancy, and how do you diagnose a molar pregnancy on TVS? You diagnose it by, in a complete mole, you will only find cystic spaces and you will not find a pregnancy with a fetal heart. You can find in a partial mole a pregnancy with a fetal heart and as well as cystic changes. You do not get the snowstorm appearance anymore. That is to get it on a B mode ultrasonography, which we no longer do. So what we need to do is to have a baseline beta ECG, because following treatment, this is how we will look at her prognosis, how she's recovering. We also do a thyroid function test and an X-ray test. All molar pregnancies require a suction evacuation. They tend to bleed a lot, so we need to keep blood ready. In women with molar pregnancy, we do not do a cervical preparation with misoprostol because there is a risk of dissemination of the molar tissue. But while we are after starting the procedure, we give a syntocinon shot and, if necessary, a syntocinon infusion. What we do is, after evacuating the uterus, we send it for histology. If it shows a complete mole or a partial mole, then we follow it up with serial beta ECG. If it says it's a choriocarcinoma, then it's a completely different line of treatment that we'll go on to, and she will require essentially a single agent chemotherapy with methotrexate or a multi-agent chemotherapy. But essentially with molar, if we see just a molar pregnancy, we will do a serial beta ECG till the beta ECG comes down to normal, and then we'll do a monthly beta ECG for 6 months, or we can even do a monthly urine pregnancy test for 6 months. Next slide, please. Now, the TVS can be inconclusive. If the TVS is inconclusive, the diagnosis is a pregnancy of unknown location. A pregnancy of unknown location could be either an early viable intrauterine pregnancy, but it is so early, it doesn't show up on scan. It could be a failing intrauterine pregnancy, or it could be an early ectopic pregnancy. So how do we monitor them? We monitor them with serial beta ECGs and follow-up transvaginal sonography. When we repeat the sonography, it will depend on how the beta ECG levels are behaving. If once the beta ECG level goes past 1500, we will think of repeating a TVS. Or if the patient's symptomatology changes or she develops pain, that is when we would repeat the TVS. Next slide, please. Now, we move on to ectopic pregnancy. Ectopic pregnancy is well recognized for over 300 years. And the first complete report came in 1731. Next slide, please. Now, the UK incidence is approximately 1%, the ectopic pregnancy. And if you look at the older reports, it is approximately 1 out of 250 ectopic pregnancies used to die in the United Kingdom. So the key in preventing mortality in ectopic pregnancy is to diagnose it early. Once there's a ruptured ectopic in shock, the morbidity and mortality increases. 95%, previous slide, please. I'm not finished. Yeah, 95% of ectopic pregnancies are tubal, and majority of them are ampullary. Ischemic pregnancies rupture sooner. Ampullary pregnancies take longer to rupture. Cornual ectopics take even longer to rupture. In 85% cases, the corpus luteum is on the same side as in the ectopic, and it is useful in locating the site of ectopic pregnancy on TVS. Early diagnosis, as I said, is the key, because not only it reduces mortality and morbidity, it also leads to less invasive therapy. Next slide, please. Now, how do you diagnose ectopic pregnancy? A positive pregnancy test with abdominal pain, you do an ultrasound. If you find an ectopic on the ultrasound, then your diagnosis is established. And these days, Just having an empty uterus is not enough to say that you've diagnosed an ectopic pregnancy. You should be able to see an adnexal mass to say that you have an ectopic pregnancy. If you can't, it is a pregnancy of unknown location. As I said before, if you see an intrauterine pregnancy, it is unlikely to be ectopic, although you remember that heterotopic pregnancy traditionally, the traditional teaching is occurs between 1 in 10,000 to 1 in 30,000 pregnancy, but it's much more common in ART pregnancies. The threshold levels for detecting an intrauterine pregnancy in serum beta hCG is 1,500 to 2,000 for transvaginal sonography and 6,000 to 6,500 for transabdominal sonography. Next slide, please. Now, how do you diagnose ectopic pregnancy on TVS? Please remember that we do not see a pseudosac on a transvaginal sonography. It's actually a transabdominal feature. The most appropriate TVS criteria is a non-cystic adnexal mass. And in the non-cystic adnexal mass, you can see a ring of fire pattern, which means that if you turn on your color flow, you'll see color flow going from the periphery. And sometimes you might find a live ectopic pregnancy where you'll see a fetal heart. Now, non-cystic adnexal mass has a positive predictive value of 96% and a specificity of 99% and a sensitivity of 84%. Next slide, please. So as I said, to diagnose ectopic, you need a high index of suspicion. The second important point not to miss ectopic is there are women who come to the emergency saying that I have missed my period. Last period was 2 months back, and today I started bleeding heavily. And I pass some solid bits, and the patient comes in and you do a sonography and you may see the uterus is empty and you make a diagnosis of complete miscarriage. Is it a complete miscarriage? Most likely, yes, but not invariably. Women are quite variable in their assessment of blood loss. So you might actually be dealing with an ectopic pregnancy. So the diagnosis of complete miscarriage cannot be made on the basis of a single TVS. So essentially, you would need a follow-up urine pregnancy test or a follow-up beta hCG to see that it is falling to confirm the diagnosis of a complete miscarriage. And essentially, you do that by either serial hCG estimations, or you can do a urine pregnancy test later on to see that it has become faintly positive or it's become negative. Next slide, please. Although sometimes it can take longer to become negative. Looking at risk factors for ectopic pregnancy is a complete waste of time. You know, we were taught in our textbooks, and maybe even now there are textbooks which say that the triad of ectopic pregnancy and the triad of ectopic pregnancy is amenorrhea, pain, and bleeding. Unfortunately, if you go by amenorrhea, pain, and bleeding, you'll miss a lot of ectopic pregnancies. And essentially, if you look at risk factors, there are only two risk factors that stand out. If a patient has had a prior ectopic pregnancy, then she's 3 times more likely to have an ectopic pregnancy. If she had 2 prior ectopic pregnancies, she's 16 times more likely to have an ectopic pregnancy. Looking at any other things is essentially not a very good way to diagnose an ectopic pregnancy. Next slide, please. Again, age, history of abortion, essentially do not help much. But more importantly, there is no association with prior non-tubal pelvic surgery, a past IUCD use, a prior cesarean section, or a current cervical infection. Of course, if somebody has an IUCD at the present moment, IUCDs are more effective in preventing intrauterine pregnancy rather than ectopic pregnancy. So you will see a relative increase in more diagnosis of ectopic pregnancy if somebody has a current IUCD, but a past IUCD use does not increase the risk of ectopic pregnancy. Next slide, please. Can I go to the previous slide? Did I miss a slide? Yeah, next slide, please. Now, how do you manage ectopic pregnancy? There are 3 ways of managing ectopic pregnancy according to the book. Number 1 is an expectant management. Number 2 is a medical management. Number 3 is a surgical management. Nobody manages ectopic pregnancy expectantly. Expectant management of ectopic pregnancy is always by accident, which means that it is a pregnancy of unknown location. And by the time we've diagnosed it to be an ectopic, the beta hCG is already started falling. And that is the time when we might withhold an intervention and just follow up the beta hCG. And that is what is essentially expectant management of ectopic pregnancy. The medical management is essentially with methotrexate. Now, this is a meta-analysis of single-dose methotrexate, which was published in 1998. And they showed that with single-dose methotrexate, the success rate in treating ectopic pregnancy varied in different studies from 70 to 100%. And the criteria for medical management that came out of these studies were an ectopic pregnancy size of less than 3 centimeter in diameter, no hemoperitoneum in TVS, and if the crown rump is visible, which means if you can see an embryo in the ectopic sac, there should be no cardiac activity. Methotrexate doesn't work well when there's a live ectopic pregnancy. Next slide, please. Now, this is another study which looked at 58 cases, and they showed that methotrexate failed in around 15% cases, and a second dose was needed in around 15% cases. And they showed that the main predictors of treatment failure was the presence of an embryo. If the baseline beta ECG when you gave the methotrexate was more than 3,000, if there was a subchorionic tubal hematoma in the ectopic gestation, or if the day 3 follow-up beta ECG was more than 3,500. Now, how do you monitor up when you give a patient a methotrexate? What you do is you do a baseline beta ECG, and then you do a beta ECG again after 3 days, and then you do a beta ECG after 7 days. Now, when you do a beta ECG after 3 days, a mild increase in the beta ECG is common, and that can be up to 15%. But if it is more than 15%, it is more likely to be a failure. By the time day 7 comes, between your day baseline beta ECG to day 7 beta ECG, there should be at least a fall of 15% to say that the methotrexate is working. Next slide, please. The UK dose is a single dose on 50 milligram per meter square. And essentially, if the beta ECG doesn't fall by 15% between day 1 and day 7, then you need to give a second. You can offer a second dose. And this study showed that you approximately 13% need a second dose. What is the failure rate of methotrexate? It varies between 7 to 10%. The Americans like everything more, so they give a multi-dose approach, and they give 1 milligram per kg of body weight on day 1, day 3, and day 5, 3 doses, with an oral folinic acid rescue on day 2, day 4, and day 6. We have sometimes used this when we've given methotrexate for women with a beta ECG higher than 3,000 or in cornual ectopic pregnancies. Once upon a time, there was a debate whether you should inject the methotrexate into the ectopic sac or whether you should give it by the systemic route, and studies showed that there are similar success rates. So essentially, there's a paper which published in 2013 in the international journal, the FIGO journal, and that is a very good one to essentially counsel women. If women say, what are my chances of succeeding with methotrexate? The answer is approximately 75% respond to 1 dose, approximately 15% will need a second dose, and about 10% will require a surgical intervention. Now, do we always have to wait till day 7 to say that the treatment is not successful? No, there is this paper published in 2017 which showed that if you see a drop of 6% between day 1 to day 4, that's possibly a better predictor of success of methotrexate treatment. Next slide, please. Then again, this is a study of 108 unruptured ectopic pregnancies, and they looked at single versus multiple doses, and they had similar success and complication rates. And the RCOG guideline of 2010 says that 15% will require a second dose, 7% have a risk of rupture, and it is more suitable when beta ECG is less than 3,000. So essentially, we can say that methotrexate, please move on to the next slide. Next slide, please. We can say that the methotrexate works best when the day 1 beta ECG is less than 3,000, when the ectopic pregnancy size is less than 3 centimeters, there's no fetal heart, and there's no hemoperitoneum. And we should use a single dose systemic, which is 50 milligram per meter square. 15% would require a second dose, and surgical treatment would be required in less than 10% of women. Next slide, please. NICE 2012 summarized the use of methotrexate very nicely. And they said, you should offer methotrexate as first line if, the most important one, the woman can return for follow-up promptly. Number 2, that she has no significant pain, the beta ECG is less than 1500, the adnexal mass size is less than 3.5 centimeters, there's no fetal heart, and there's no intrauterine pregnancy. Offer the women both surgery and methotrexate if the beta ECG is between 1500 to 5000 and everything else stays the same. Next slide, please. Now, next we come to the surgical treatment of ectopic pregnancy. Now, laparoscopy is the route of choice. In hemodynamically unstable patients, we usually do laparotomy, but that's a relative contraindication. It depends on the competence of the surgeon and the anesthetist at how much at what stability, hemodynamic stability, you can still do a laparoscopy. We can do either a salpingectomy or a salpingotomy. I will come to that in a moment. But if you do a salpingotomy, you need to follow up with a serial beta ECG based on the risk of persistent trophoblast. There is a study which showed that there is no difference in ovarian response in subsequent IVF, whether the ectopic pregnancy is treated with methotrexate or with salpingectomy. Next slide, please. So why should we say laparoscopy is a treatment of choice? There are 3 randomized controlled trials which looked at about 228 patients, and they showed that laparoscopy was associated with less intraoperative blood loss, shorter operating times, shorter hospital stay, lower analgesic requirements, and there was no difference in subsequent intrauterine pregnancy rates, but there was a trend towards lower future ectopic pregnancy rates with laparoscopy. Next slide, please. Laparoscopy provides more rapid access to abdomen. If it is a lot of hemoperitoneum, the surgery total might take longer time to clean the abdomen, but it is gives you more rapid access, and you can stop the bleeding sooner than in a laparotomy. It's a shorter surgery with less blood loss, less extensive postoperative additions, faster recovery, and lower cost of hospitalization and rehabilitation. Women can go back to their normal life and work sooner. Next slide, please. Now, should you do a salpingectomy or salpingotomy? Now, this is a matter of debate, because if you do a salpingectomy, you're removing a diseased uterus, diseased tube, so the risk of subsequent ectopic should be less. If you do a salpingectomy, then theoretically, you might decrease her chances of getting pregnant next time. Now, there are reviews published with many cohort studies, but then there was one recent large cohort study, and then there were 2 recent randomized trials. Next slide, please. Yeah, these are the cohort studies, and if you look at them, this is a study of 143 women, which showed that the intrauterine pregnancies were similar, whether you do a salpingectomy or salpingotomy, and the intrauterine pregnancy rates were similar, and there was a trend towards higher subsequent ectopic pregnancy in the salpingotomy arm. And next slide, please. But almost at the same time, similar times, 3 other studies came which showed that there was a trend towards improved subsequent intrauterine pregnancy rates with conservative surgery, which means with salpingotomy, subsequent intrauterine pregnancy rates were higher than compared to salpingectomy. Next slide, please. If this such study showed the same thing, better pregnancy rates with salpingotomy. Next slide, please. And same. Next slide, please. Now, based on these cohort studies, the Americans suggested that laparoscopic salpingotomy should be your treatment of choice, although the RCOG guidelines said if the other tube looks healthy, then you should do a laparoscopic salpingectomy. Next slide, please. So this is what actually was the RCOG versus the American guidelines. Next slide, please. But things changed with these 3 studies. Now, this study was published in BMJ in 2015. This was a retrospective cohort study of 618 patients, much higher than any of the earlier ones, in which majority of the patients had salpingectomy, some of the patients had salpingotomy, and some had tubal anastomosis as well. And it showed that the intrauterine pregnancy rate with salpingectomy and salpingotomy, future intrauterine pregnancy rates were similar. The intrauterine pregnancy rate with anastomosis was slightly lower. The risk of persistent trophoblast was higher as expected in salpingotomy, and the risk of ectopic pregnancy was more or less similar in salpingectomy and salpingotomy. Next slide, please. Now, this is the first randomized control trial published in 2013, which looked at methotrexate versus salpingostomy and salpingostomy versus salpingectomy, and it showed intrauterine pregnancy rates were similar. Next slide, please. And this is a ASEP trial, which was published the following year, which showed that the intrauterine pregnancy rates after salpingectomy or salpingotomy were statistically not significant, and it doesn't take a rocket scientist to tell us that if you do a meta-analysis of these 2 randomized controlled trials, it will show that there is no difference in intrauterine pregnancy rates with salpingectomy or salpingotomy. So the current teaching is if the contralateral tube is diseased or is absent, then we should do a salpingotomy. If the contralateral tube is healthy, we should do a salpingectomy. As with salpingotomy, there is similar subsequent intrauterine pregnancy rates, and a query, possibly there is a small increase in subsequent ectopic pregnancy rate, but there is an increased risk of persistent trophoblast, for which we need to follow up the woman with beta ECG levels. Next slide, please. Well, I think this is why the video was having a problem. I don't think the video will play, right? Oh, this is a scar pregnancy. I think I will skip the video. Scar pregnancies become very common. That is because of too many cesarean sections that are happening. This can continue, means I'll just talk about scar pregnancy. But essentially what happens in scar pregnancy, the typical history is that the patient had a sonography which showed an intrauterine pregnancy, not a very good sonography, so they didn't raise a suspicion of scar ectopic, because scar pregnancy you will not find unless the sonologist is looking for it. And then the patient had a medical termination, had bled quite a lot, and then the bleeding stopped. The patient went home and then came back with heavy bleeding, and the ultrasound showed a small hematoma in the lower uterine segment in the region of the scar. These are typical scar pregnancies, and these days our sonologists are much more aware, so we can find them. The best treatment is by laparoscopy, and as in this case, what we do is we open the UV peritoneum, and you can see that the scar has given way, and we inject some vasopressin into the uterus, and then we clean the entire scar pregnancy very well, and then we close the defect. You can freshen up the edges and close the defect in a single layer. It can also be treated with methotrexate. We have treated one scar ectopic pregnancy with methotrexate with reasonable success, but I think surgical treatment is the treatment of choice. Next slide, please. Now we move on to miscarriage. Now, please remember, miscarriage is very common. The incidence of miscarriage is about 15%, which means 1 in 7 pregnancies end up in a miscarriage. If we include biochemical loss, which is the pregnancy test is positive but nothing visible on sonography, then the incidence of miscarriage is 1 in 4. The incidence of recurrent miscarriage, if you take the definition as 3 consecutive miscarriages, is 1 to 2%. If you consider 2 pregnancy losses as recurrent miscarriage, then the incidence of recurrent miscarriage is around 5%. Next slide, please. Now, this is a very old paper from 2000, but it is very interesting because it shows that the miscarriage risk stays the same from the adolescence till the age of 35 years. And from 35 years, it starts rising rapidly. So maternal age is a very important criterion. The risk of miscarriage from the age of 35, the risk of miscarriage increases. Between 35 to 40, the miscarriage risk increases from 15% to 25%. From 40 to 45, half the pregnancies end in a miscarriage. Beyond 45, majority of the pregnancies end up in a miscarriage. Next slide, please. Now, what are the different kinds of miscarriage? One is threatened miscarriage. Threatened miscarriage is when there is vaginal bleeding, a live pregnancy, but no cervical dilatation before the 20 weeks of gestation. Recurrent miscarriage, 3 or more consecutive pregnancy loss. But we are now of the opinion, everybody is of the opinion that we should investigate after 2 consecutive pregnancy losses. Inevitable miscarriage, where the os is dilated, but the products of conception have not been expelled. Septic miscarriage, whereas spontaneous miscarriage is complicated by intrauterine infection. Next slide, please. Miscarriage, when the fetus die in utero, but there is no uterine activity to expel the products of conception and they are retained. Incomplete miscarriage, when part of the products of conception have been expelled and the cervical os is closed, and ultrasonography reveals that there are remaining products of conception in the uterus. And a complete miscarriage, when all products of conception have passed and the os is closed. Next slide, please. So miscarriage is better, we should better call it as early pregnancy loss or early embryonic demise, because women don't like to hear the word miscarriage. And it is defined by NICE in 2012 as a non-viable intrauterine pregnancy with either an empty gestational sac or a gestational sac containing an embryo or fetus without fetal heart activity, usually within the first 12 weeks of pregnancy. Now, what happens in a normal pregnancy? In a normal pregnancy, first the intrauterine sac appears, then the yolk sac appears, then the CRL, then is a measurable CRL, and then the fetal heart develops. So while you are diagnosing a miscarriage, you need to be very careful that you do not diagnose an early intrauterine viable pregnancy as a miscarriage, which means that you are not as a CRL without a fetal heartbeat can be an early uterine pregnancy viable, or it could be a miscarriage. Move next slide, please. I will come to that, the diagnosis in a moment, but miscarriage is 10% of all clinically recognized pregnancies. About 80% of them occur within the first trimester, and the common risk factors include advanced maternal age, a previous early pregnancy loss, increased risk in infertility or assisted conception. It is also associated with smoking, obesity, hypothyroidism, and uncontrolled diabetes mellitus. Next slide, please. It is usually asymptomatic. Occasionally, patients might have mild vaginal bleeding or spotting and uterine cramping, which then stops. It is important to distinguish it from other early pregnancy complications. We need a thorough medical history, physical examination, ultrasound, and a serum beta ECG sometimes to be making a diagnosis. Next slide, please. Now, TVS is the preferred modality. The initial ultrasound criteria were described in 1990s, where we used to say that if you have a mean sac diameter of more than 20 millimeters without an embryo, then it is a miscarriage. We used to say if you have a CRL of more than 5 with no fetal heart, then it is a miscarriage. But due to the low specificity and high false positive rate, studies were done thereafter and the criteria changed. And the Society of Radiologists essentially in ultrasound multi-specialty panel on early first trimester diagnosis of miscarriage and exclusion of a viable intrauterine pregnancy. This group contained radiologists and obstetricians, and they created guidelines in 2013, which are considerably more conservative than the past recommendations and have stricter cutoffs than the studies on which they are based. Next slide, please. So at the present moment, finding suggestive of a miscarriage, diagnostic of a miscarriage is when the crown rump length is 7 millimeter or more with no heartbeat, a mean sac diameter of 25 millimeter or more and no embryo, absence of an embryo with heartbeat 2 weeks or more after a scan that showed a gestational sac without a yolk sac, and absence of embryo with heartbeat 11 days or more after a scan that showed a gestational sac with a yolk sac. And this is a very important point, very important slide. So you can diagnose miscarriage based on one scan only if the CRL is 7 or more and no heartbeat, the mean sac diameter of 25 millimeter or more and no embryo, or based on 2 scans, when you find that there is no embryo with heartbeat 2 weeks after you saw gestational sac without a yolk sac, or 11 days after you saw gestational sac with a yolk sac. Next slide, please. Next slide. Yeah. Now, what happens? Previous, please. Yeah. What are the findings that are suggestive but non-diagnostic of a miscarriage? That is everything that falls in between the old criteria and the current criteria, which means a crown rump length which is between 5 to 7 millimeter and no heartbeat, a mean sac diameter of 16 to 24 millimeter and no embryo, absence of embryo with heartbeat between 7 to 13 days of an ultrasound which showed a gestational sac without a yolk sac, or absence of embryo with heartbeat 7 to 10 days after an ultrasound scan that showed a gestational sac with yolk sac. So essentially, these are meaning that this is a possible miscarriage, but we should wait and see that whether it is really a miscarriage or not. So we should call the patient, call the woman for some repeat sonography after 10 to 14 days, 11 to 14 days, depending on whether we saw yolk sac or not. Also, there are other things which are suggestive that it might go into miscarriage, which is an absence of an embryo for 6 weeks or longer after a last menstrual period, an empty amnion, an enlarged yolk sac which is more than 7 millimeter, or a small gestational sac in relation to the size of the embryo. Next slide, please. So how do you manage miscarriage? By either expectant method or medical or surgical. All these 3 methods are shown to be reasonably effective and acceptable, and there is no evidence that any approach results in a different long-term outcome. Next slide, please. So conservative management should ideally be limited to the first trimester with adequate time. Complete expulsion is achieved in 80% of women, but that adequate time is 8 weeks, and nobody would like to wait for 8 weeks. So I don't think anybody would wait between 1 to 2 weeks, but the woman requests some time, you can always give them some time for conservative management. But women who are symptomatic, who've already started bleeding, a conservative management is more effective in them. You need adequate counseling with a follow-up ultrasound to make sure that all the products have been expelled. Next slide, please. Next slide, please. The medical management is with misoprostol. Misoprostol reliably reduces the need for uterine curettage, and the success rate of 400 and 800 are comparable. vaginal and sublingual are more effective than oral. So oral should not be given. You should either give a vaginal route or by sublingual route. Sublingual is better in a woman who's not bleeding. Now, the success rates were in the range between 65 to 70%. And the earlier, this is a fallacy of evidence-based medicine. The earlier studies said that addition of mifepristone is not necessary, but then it didn't have the adequate numbers. So in the New England Journal in 2018, this study was published, which compared mifepristone plus misoprostol versus misoprostol alone. And they showed the addition of mifepristone increases the success rate of medical management from 67% to 84%, also reduces the need for an uterine aspiration from 23% to 9%. So we should give them mifepristone 200 milligrams, and 36 to 48 hours later, we should give them misoprostol, preferably 800 microgram, vaginal or sublingual, depending on whether they are bleeding or not. Next slide, please. Surgical management is the traditional approach, especially indicated for women who are hemodynamically unstable or those who have medical comorbidities. Suction evacuation is superior to sharp curettage. The success rate is almost 99% and not 100%, because many surgical management would require a repeat evacuation because some written products have been there. Despite lack of data, preoperative antibiotic prophylaxis, essentially for chlamydia, should be considered. And you could give them essentially 1 gram of azithromycin the day before, the night before the procedure, or you can give them essentially 7 days of doxycycline. Now, what about threatened miscarriage? We've already defined what is threatened miscarriage. It may be accompanied by mild cramps and back pain. It occurs in around 20% of all clinically recognized pregnancies. It could be an implantation bleed because it takes 12 weeks for the entire endometrium to be replaced by decidua. So especially at the time of the period, there could be some bleeding. But then any bleeding in the first trimester is diagnosed as threatened miscarriage. It is only in retrospect that we can say that this could have been an implantation bleed and was harmless. Next slide, please. Next slide. Next slide, please. Hello. Next slide. Yeah, treatment. Please don't allow bed rest. Bed rest has no role in treatment of miscarriage. As far as uterine relaxants, there is insufficient evidence, so they're rarely used. Does HCG have some role? The HCG, there's a small randomized study which showed it to be significantly more effective than bed rest, but a double-blind randomized study failed to show any difference. So at the present moment, we really do not offer them HCG, but we offer them progesterone in the form of either dihydrogesterone or micronized progesterone by the vaginal route. Next slide, please. So this is a Cochrane review published in August 18 of progesterone for threatened miscarriage. And this is before the PRISM trial came in. I will speak on the PRISM trial, I guess. It showed that progesterones did reduce the risk of miscarriage in threatened miscarriage. And they showed that oral progesterones reduce the risk of miscarriage by around 43%, and that is dihydrogesterone. And vaginal progesterones had little or no effect. This is before the PRISM trial. And so essentially for threatened miscarriage, they recommended giving them oral dihydrogesterone. Now, there is a lot of controversy about how much dosage of dihydrogesterone should be given. There are 3 trials. One of them used a loading dose of 40 milligram followed by 10 milligram 3 times a day. The other 2 did not use a loading dose. Some of those one trial stopped the dihydrogesterone as soon as the bleeding stopped. One trial stopped the dihydrogesterone a week after the bleeding stopped. One trial continued the dihydrogesterone till the end of the first trimester. So we still do not know what is the right dosage, but we do know oral dihydrogesterone is beneficial in threatened miscarriage. Next slide, please. Now, this is the PRISM trial, which was done in the United Kingdom, published in 2019, and it's a randomized controlled trial of 4,000 women of threatened miscarriage. Half of them required micronized vaginal progesterone 400 milligram twice daily till 16 weeks, and half received placebo. And this was after excluding, the inclusion criteria included a viable pregnancy and hemodynamically stable patient. Now, they showed that across the board, there was no improvement or prevention of miscarriage by giving them the vaginal micronized progesterone. And in subgroup analysis in women with no previous miscarriage, there was no benefit of giving them vaginal progesterone if they had a bleeding. Next slide, please. Next slide, please. Yeah, but in subgroup analysis of women with previous 1 or 2 miscarriage, there was a small increase in live birth with vaginal micronized progesterone. But in women with previous 3 or more miscarriage, there was a significant increase in live birth with vaginal micronized progesterone. So at the present moment, we do recommend vaginal micronized progesterone in women with previous miscarriage who present with a threatened miscarriage. Next slide, please. This study has again been validated in other trials, which have shown that essentially progesterones to prevent miscarriage is a cost-effective intervention, especially in women who had a previous miscarriage and early pregnancy bleeding. Next slide, please. That brings us to the last part of the talk, and which is on essentially on recurrent miscarriage. Next slide, please. As you know that the definition is 3 or more consecutive pregnancies that end in miscarriage before 20 weeks. But according to ASRM and ASHRAE, the current definition should be changed to 2 or more consecutive miscarriage. And it affects, if you take the definition as 2, then the incidence is around 5%. The problem is that in more than 50%, we cannot find a cause. That doesn't mean that there is no cause, but that just means that our science doesn't have answers to what the etiology could be in recurrent miscarriages. But recurrent miscarriage is definitely an entity, because we said right at the start of this talk that the incidence of miscarriage in a pregnancy is 15%, which is the incidence of sporadic miscarriage. So if we think a woman might have 3 consecutive miscarriages just by statistical chance, then the incidence of recurrent miscarriage should have been 0.3 or 0.4%. After 3 miscarriages, or approximately around 2.2% after 2 miscarriages. But you can see that the incidence of recurrent miscarriage is 1 to 2% if you consider the definition as 3, and 5% if you consider the definition of 2. So majority of recurrent miscarriages must be having a cause, and they are not just subsequent sporadic successive sporadic miscarriages. Next slide, please. Okay, this study essentially shows that as your number of miscarriages increase, your chance of miscarriage increases. So after 1 miscarriage, there's not much increase in the risk of miscarriage. But after 2, the risk of miscarriage is 25%. After 3, the risk of miscarriage is around 45%. But the good news is that even after 3 miscarriages, the risk of taking home a baby is over 55%. Next slide, please. I wouldn't say these are etiological factors of recurrent miscarriage, because we don't understand a lot of them as very well. But there are epidemiological factors. These are risk factors which are associated, maybe having an etiological point as well in some of them. Epidemiological factors means we know maternal age. Antiphospholipid syndrome is definitely a causative factor for recurrent miscarriage, and that is why we'll discuss this in details. Genetic factors, anatomical factors, especially a septate uterus has been implicated in a cause of miscarriage. Endocrine factors are usually not a cause of miscarriage, because they give rise to hypothyroidism, poorly controlled diabetes give rise to sporadic miscarriages, not recurrent. Immune factors are a matter of research. Infective agents are usually not a cause of recurrent miscarriage, because for an infective agent to cause recurrent miscarriage, it has to reside in the genital tract and escape diagnosis. And we haven't found an organism like that. Inherited thrombophilia, again, is a risk factor, is a matter of debate. Next slide, please. So what investigation should we do as first line? The most important test to do is to do the cytogenetic studies of the products of conception on the second miscarriage. Now, if you have an access to an array-based comparative genomic hybridization, or what we call is a molecular karyotyping, that is the test to go for. If you do not have access to that, sending the POCs to a far-off place for traditional karyotyping, it might not grow anything, so it is important to send it for fish as well. And in fish, they look for essentially the chromosome number 13, 18, 21, and the 6 chromosomes. This is the most important investigations to be done. The second investigation to be done is antiphospholipid antibodies. I'll talk in detail about how to test for that. We should do a peripheral blood karyotyping of both partners only if the cytogenetic studies of the products of conception are abnormal or they indicate a translocation. We should do a transvaginal sonography, especially if it's a second trimester miscarriage. And if we suspect a uterine anomaly, and if we suspect a septate uterus, how do you suspect a septate uterus? By seeing a very thin endometrial thickness, especially in a postmenstrual scan. Then you can do a hysteroscopy combined with a laparoscopy or a 3D ultrasound, depending on what resources are available to you. If none of these tests show anything, then you can go on to your second line of testing, which is testing for inherited thrombophilia, especially in second trimester miscarriage, but you do not have to do a whole screen. You can only do a factor V Lenin mutation, prothrombin gene mutation, and a protein S level, because these are the only three who've been implicated with recurrent second trimester miscarriages. The earlier ESHRE guidelines said that we should test for ANA, and if it is positive, we should not treat. So I would still reserve ANA as a second line of investigation. Next line, please. So about thrombophilia, the acquired thrombophilias are more important, and what we can test for commercially at the present moment are lupus anticoagulant, which is the most dangerous. Means if you have lupus, your chances of pregnancy loss is higher than if you have anticardiolipin antibodies. And with anticardiolipin antibodies, your chances of pregnancy loss are higher than if you have beta-2 glycoprotein antibodies. Annexin antibodies is still not commercially available for testing. Among the inherited thrombophilias, I said earlier, factor V Lenin mutation, prothrombin gene mutation, and protein S deficiency have been implicated in recurrent second trimester pregnancy loss. Next slide, please. Next slide, please. Next slide. Yeah, the previous, please. The previous one. Next. Yeah. Now, what is antiphospholipid antibodies? Antiphospholipid antibodies is the persistent presence of either lupus anticoagulant or anticardiolipin antibodies or beta-2 glycoprotein antibodies on two separate occasions at least 12 hours, 12 weeks apart. Next slide, please. The prevalence of antiphospholipid antibodies in a normal population is around 2%. Women with SLE, about 30 to 40% of them will test positive for antiphospholipid antibodies. Of women who have antiphospholipid antibodies, 30% of them undergo I think we've lost Dr. Murli Pai.
Yes, sir.
Can you call him, please?
Yes, sir. Calling, sir. Just a moment.
So I would continue. About 30 to 40% of women with SLE will have antiphospholipid antibodies. Women and men who carry antiphospholipid antibodies, about 30% of them will have a thrombosis in their lifetime. 30% of women who have severe preeclampsia or a severe IUGR, which necessitates a delivery before 34 weeks, have antiphospholipid antibodies. Among women with recurrent pregnancy loss, about 15 to 20% have antiphospholipid antibodies. The problem is that women with antiphospholipid antibody syndrome, which is the presence of antiphospholipid antibodies and a poor outcome, poor obstetric history, if you do not give them any treatment, the live birth rate is around 10%. And if you give them a treatment, then the live birth rate increases from 10% to 90%. Have you found Dr. Pai?
Just couple of minutes, he will be joining, sir.
Okay. So how do you test for antiphospholipid antibodies? You test for all three of them differently. Lupus anticoagulant, you test by an indirect method. You can do an activated, you can do an APTT, you can do a kaolin clotting time, but the most sensitive test is the dilute Russell Viper venom test. Anticardiolipin antibodies and anti-beta-2 glycoprotein antibodies, you test them by IgG and IgM. What we know, and if you look at the old RCOG guideline, it does say that considerable inter-laboratory variation occurs in antiphospholipid testing due to suboptimal sample collection, suboptimal sample preparation, lack of standardization, and temporal fluctuation. So sometimes you might have a patient with a history which is very suggestive of antiphospholipid antibodies, but the test essentially comes back as negative. And one of the common mistakes is if you're transporting it from one lab to the other lab, not to centrifuge the sample. So the sample has to be centrifuged before sending if you're testing for antiphospholipid syndromes. Dr. Pai has joined. Will just wait for him to share the screen.
Yeah, no, but Bhaskar, I am not able to share that. Laptop is not taking up the slide. It's stuck there. It's hung up. So I have joined here. If you have the slides in front of you, you can just talk looking at the slides if you have.
I can, but people will not be able to see the
only
slides. They will miss it.
I think 4 or 5 slides are left regarding the RPL.
Oh, I have a lot of slides left.
Oh, a lot of slides left. So okay, I'll just try to get it here on this.
Really sorry for this, but
I must say sorry. It's just taking 1 or 2 minutes more.
no, that's okay. I'm just trying to see if
Yeah.
I can share my slide because I have. Can I from the phone? I can. Yeah, I can.
You can share.
me
You
sh-
can,
I think let me try and
yeah,
share my screen. I have got the PowerPoint presentation open on my phone, but I really do not know how to share it.
No, you can press the same thing. You open it in your thing and then share. Yeah. Because of that video, it's a big one. It's taking.
Yeah, I deleted 2 videos. I forgot
Yeah.
to delete. I did not realize that video was there.
Yeah, it's okay.
No, I am unable to share.
Okay, okay. I think mine is opening. It's okay. Yeah, it opened. It's just a minute. Arun, Arun,
Yes, sir.
how to share from the mobile?
Sir, you must join into the Zoom, sir. Same thing.
I have joined already. So
Same
I
thing.
should open it in my mobile and then
Yes.
share it.
Yes, from files, sir.
From files. Okay.
Yes, sir. It will be downloaded in files.
Yeah. Okay. It's already open.
So can you send me, sir?
Yeah. Okay. Okay. I'll send you that. I think I'll send you. I have sent. You will receive it.
Yes, sir. Waiting. Sir.
Okay. Can I see it now?
Not yet, sir.
Not yet. Miguel Hajgraja Rakha. Arun, did you get the email PPT?
Yes, sir. I got the PPT, but it's
Getting
it's
downloaded.
taking time, sir. Yes, sir.
Yeah. Anyway, we'll wait. It should be coming in another 2 minutes. So
Yes, sir.
yeah. Sorry, Bhaskar, it will come in another 2-3 minutes.
No, that's okay. It's I've just uninstalled my Zoom and trying to install Zoom again.
Sir, I got it, sir, but I can't enlarge it, sir. Can I share it, sir?
Let's hope I'm trying to open it here. Let's see.
Well, I think I have some success with the Zoom. Let me see.
Okay. So shall I stop sharing that?
Yes, sir.
Yeah, please.
No, I
let
got
me
it.
Just.
I think I got it. Can you see now?
It's loading, sir.
Yeah.
Can't open file. Try opening in the mobile app. Open in one. Sir, you stop sharing, sir.
I'll stop sharing. Okay.
Sir, meanwhile, shall I share, sir?
You share if you have got it.
Yes, sir.
Well, I have managed to join. I have
Okay.
managed to join from another device. So I'm leaving from here and I will share my screen.
Okay. Okay.
Okay, sir.
Finally.
Finally. Great.
This much I can.
Oh, so this is your sharing now.
Yes, sir.
Oh, then you make it a slideshow there.
This size, sir.
Down there. That
Yeah,
one.
slide share it
Can I
taking
share my screen,
too
please?
much time, sir.
It is taking
Hello.
too much. Just
Yes, sir.
click it and see.
Am I audible?
Yeah. You are audible. Actually, now you can see the
Now,
slide.
sir.
Yeah,
Am I audible?
Good. You are audible, Bhaskar.
Yeah.
And we have shared the slide for you.
I think now that I have come in, I can also share.
No, but already the slides are on the
That's
screen.
fine. That's fine. Please go back to slide 67.
67. Okay. One more. Go back. Go back, Arun.
Sir, it's moving, sir.
Okay.
So it's taking time.
Yeah.
No, but I think I can, Arun, if you stop it, I will share my
Arun, you
Okay,
stop
sir.
sharing.
Okay, sir.
Please stop sharing.
Yeah.
Just give me.
Yeah.
Can you see my screen?
Yes.
Hello?
Yes.
Yes, sir.
Thank you.
Yes, sir.
Okay. So
thank God.
thank God. I had to so this is what I have already spoken, that this is how you test for antiphospholipid antibodies. Lupus anticoagulant you test is indirectly. The best method is dilute Russell Viper venom test. Anticardiolipin and beta-2 glycoprotein antibodies you test by IgG and IgM. Now, what is antiphospholipid syndrome? It's not the mere presence of antiphospholipid antibodies. It is the presence of antiphospholipid antibodies along with either association of thrombosis or adverse pregnancy outcome. Now, the thrombosis could be venous. It could be unusual sites like in the brain, or it could be arterial or small vessel. What is an adverse pregnancy outcome? Either of the three. Either 3 or more consecutive miscarriages are under 10 weeks. 1 or more late miscarriage, which is beyond 10 weeks with a normal fetal morphology, the one we talk about that after 10 weeks when the fetal heart is positive. 1 or more premature death, premature birth before 34 weeks with a normal fetal morphology due to severe preeclampsia or severe placental insufficiency. Now, how should recurrent miscarriage be managed? It is best managed in a specialist clinic. If there is an abnormal karyotype, do a geneticist referral. Why is best managed in a specialist clinic? Is because tender loving care is been shown, or TLC has been shown to have a live pregnancy rate of around 75%, and that is essentially because of allaying her anxiety, doing counseling, doing scans, etc. If it's an abnormal karyotype, do a geneticist referral. PGD is proposed if there's a balanced translocation, and there is no role of PGD plus IVF if there is a unexplained recurrent miscarriage. If there is a septum and there is early recurrent miscarriage, a septum resection is recommended. History indicated cerclage versus serial cervical sonographic surveillance is what you would do if there is if essentially there is a history of suggestive of cervical insufficiency. Then you can either do a history indicated cerclage, or if you're not sure from the history, then you do a serial cervical length surveillance on sonography, and you do a cerclage if the cervical length is less than 25 millimeters prior to 24 weeks gestation. Now, how do you treat recurrent miscarriage? So essentially, HCG, there is insufficient evidence. Suppression of high LH levels in women with recurrent miscarriage and PCO does not improve live birth rate. Metformin is insufficient evidence. Anatomical factors show septal resection there is some evidence. There is no role of bed rest. I already spoke about tender loving care. Now, how do you manage antiphospholipid syndrome? It depends on whether there is a history of prior thrombosis or no prior thrombosis. Now, no prior thrombosis means either recurrent early miscarriage or a late miscarriage or early delivery due to placental insufficiency. If the lady has got a prior thrombosis, then you need to do full anticoagulation in pregnancy. Now, sometimes anticoagulation in pregnancy giving in the normal dose is not enough. If you're using unfractionated heparin, you use it every 8 to 12 hours to maintain APTT at 1.5 times the control. If you're using enoxaparin, then you use 1 milligram per kg of body weight twice daily or 1.5 milligram per kg of body weight once daily. And this has to be continued 6 weeks postpartum, because the risk of thrombosis in pregnancy is the highest in after delivery. Now, what about antiphospholipid syndrome with just with no prior thrombosis but an poor obstetric outcome? We do not have a lot of randomized controlled trials, but we have to remember that these women are at a high risk of thrombosis as well. So the current recommendation is to put them on aspirin when they are trying for pregnancy, or you can start the aspirin as soon as the urine pregnancy is positive, and you start heparin or low molecular weight heparin as soon as the pregnancy test is positive, and do not wait for the fetal heart. And this essentially comes back from the Cochrane database of 2005. You can see that aspirin plus unfractionated heparin is beneficial than aspirin alone. Low molecular weight heparin plus aspirin is versus aspirin, there is only one trial. Aspirin versus placebo, there is no benefit, and so only aspirin will not work. People tried prednisolone also, and it showed that with prednisolone there was more gestational diabetes mellitus. People tried other things like IV immunoglobulin, and it showed there was increased risk of pregnancy loss and preterm birth with IV immunoglobulin. So what is the dosage of low molecular weight heparin if you are giving it on a full prophylactic dose? Essentially, for somebody who's 50 to 90 kilos, there's a 40 milligram per day. If it is 90 to 130 kilos, you give 60 milligrams. If it is less than 50, you give 20. More than 130, I think we are better off consulting a hematologist. So this is what is the current guideline. We use aspirin and heparin. Aspirin start as soon as the pregnancy test is positive, or you may even start when the patient is trying for pregnancy. Low molecular weight heparin is started when the pregnancy test is positive. No longer, the old osteology guideline is to stay, you wait for the fetal heart. So as far as inherited thrombophilia is concerned, there's a strong association of factor V Leiden mutation, prothrombin gene mutation, and proteinase deficiency with recurrent second trimester miscarriage. So women with recurrent second trimester miscarriage should essentially be screened for these thrombophilias, and if they are positive, they should also be treated with heparin. Now, this is a study from India. This is from Mumbai. What happened is that they looked at risk of thrombophilia in pregnant women. They looked at 430 women with unexplained fetal loss, And they showed that they found that with anticardiolipin antibodies or lupus anticoagulant, there was a high risk of fetal loss, and with proteinase deficiency as well, but numbers are small. So essentially, heparin may be useful in improving live birth rate in women with recurrent second trimester miscarriage, but the evidence is not great if it is a first trimester miscarriage. Now, there is a randomized controlled trial of enoxaparin versus low-dose aspirin in women with single-let miscarriage with factor V Leiden or prothrombin gene mutation and or proteinase deficiency, and it showed that enoxaparin was superior to low-dose aspirin. Now, women who are on heparin or low molecular weight heparin, we need to make some adjustments during labor and delivery. These patients can be delivered at term, but if they're on a prophylactic low molecular weight heparin dose, we need to stop the antithrombotics if the patient starts bleeding or goes into spontaneous labor. And if you're doing an elective cesarean or induction, then the last injection should be 12 hours prior to that. If the patient is therapeutic on therapeutic anticoagulant dose, we need to stop it 24 hours prior to elective cesarean or induction. If we think that the patient is on a high risk of developing thrombosis, then we can start IV unfractionated heparin, and we stop that 2 to 4 hours prior to anticipated delivery. And these women need continuous electronic fetal monitoring in labor. We can resume anticoagulation 4 to 6 hours after a vaginal delivery and 8 to 12 hours after a cesarean. In women with a prior thrombosis, we need to give prophylaxis for 6 weeks. Women without prior thrombosis, we need to give them prophylaxis for 10 days or 6 weeks. 10 days according to the Britishers and 6 weeks according to the American guidelines. But we can move them to warfarin. Warfarin is safe during lactation, but in future we should avoid estrogen in them. What about the role of antithrombotics in idiopathic recurrent miscarriage? There are several studies which have looked at the use of antithrombotics in idiopathic recurrent miscarriage or unexplained recurrent miscarriage, and whether it is aspirin or aspirin plus low molecular weight heparin, they do no better than placebo in terms of live birth rate. So what about unexplained recurrent miscarriage? What we can offer them? Now, one of the theories is that there is an abnormal immune response of the mother to the paternal antigen of the fetus, and so immunomodulation holds the key to a successful pregnancy. And a miscarriage is essentially because of the loss of balance between the T helper 1 cells versus the T helper 2 cells. Now, does progesterone help? This is essentially the old Cochrane database, which showed that they looked at role of progesterone in preventing miscarriage, and they found that in normal women there is no role of progesterone in preventing miscarriage, but in a subgroup analysis of 4 trials they found that progesterone is successful in preventing miscarriage in women with recurrent miscarriage, but they could not make a recommendation because all these trials use different progesterones by different routes and different dosages. Then came the PROMISE trial from the same group which did the PRISM trial, and this was first trimester progesterone therapy in women with unexplained recurrent miscarriage. And here, even before as soon as the urine pregnancy test was positive, even before establishing fetal viability, women were randomized into getting micronized vaginal progesterone 400 milligram twice daily or a placebo from the positive urine pregnancy test up to 12 weeks of gestation, and it showed that there was no difference in miscarriage rates or live birth rates, so there was no benefit of giving this. Now, the PROMISE trial has been criticized for several reasons. One of them is that they did not establish viability, so a lot of miscarriages possibly already has happened. And around the same time or a little earlier, this paper came from India, which showed that in a randomized controlled trial, that giving oral dydrogesterone 10 milligram twice a day from the time the fetal heart was positive till 20 weeks of gestation decreases the risk of miscarriage. Now, there is a meta-analysis of progesterone in recurrent miscarriage of 10 trials of around 1,600 women, which showed that unexplained recurrent miscarriage with progesterone supplementation, there is a lower miscarriage risk and higher live birth risk, and only synthetic progesterones are found to be useful. I've already spoken about PRISM trial, but in idiopathic RPL, there are a lot of things which are happening in research settings only and cannot be put into clinical practices yet. And they include natural killer cells in blood, endometrial tissue or decidua, HLA testing, T helper 2 cytokine levels, TNF alpha levels, and sperm DNA fragmentation test. So how do we manage idiopathic RPL? Yes, we can offer them progesterones. We did look at that. Can we offer them IVF and PGD? There are, again, in the research settings, people are looking at where IVF and PGD will help if it is a euploid pregnancy loss. Aspirin and heparin has no role. Intralipids, there is no randomized control trial. IV immunoglobulin, there is no role. Same with paternal and third-party donor leukocytes should only be used in research settings. Same with GCSF, but GCSF, there are several randomized control trials in progress. There are very limited trials already published, but they have encouraging results. So this is a look at the treatment of idiopathic RPL in a paper in 2018, which showed aspirin had 2 small trials with insufficient evidence. Low molecular weight heparin had 3 studies with no benefit. Steroids had no randomized control trial. Intralipid, no randomized control trial. IV immunoglobulin, 6 randomized control trials with no benefit. Paternal leukocyte immunization improved live birth rate in 5 small studies. Progesterone, 1 study showed benefit. Thank you and please don't forget, if somebody is a Rh negative mother, and if it is an ectopic pregnancy or if it is a miscarriage with significant bleeding or requiring evacuation, then we need to give them anti-D prophylaxis. Thank you very much.
Thank you, Dr. Bhaskar.
I'm sorry,
Extremely,
very sorry for the.
No, I am actually also sorry, because there was a lot of technical problems unusually, that too with Zoom today. And of course, our laptops also hung and those things. But I really appreciate that you have taken time out of your busy schedule, and you patiently waited for all the technical glitches. And you have really covered entire gamut of problems of the bleeding in the first trimester of pregnancy, starting from ectopics, then the abortions and the recurrent abortions. I think it was so comprehensive, and you have dealt it so beautifully with explanations, evidence, everything. I think it's amply clear now to all of us how to deal with a bleeding problem that comes up. I would now request Dr. Suman Gaddi to handle question and answer sessions, if at all, if there are any questions. Please, over to you, Dr. Suman. She is the treasurer of KSOGA.
Yes, please. Question answers, as such, I'm not okay. Able to get it.
Okay.
So,
all right. So I think it's already we have lost a lot of time. So probably we will.
What?
Yeah, we will try to wind up this session, and I would request Dr. Suman Gaddi to propose the vote of thanks. Thank you, Dr. Bhaskar, once again for accepting our invitation.
My pleasure. It was my pleasure.
Yeah. Dr. Suman.
Thank you, Dr. Pai, sir. Good evening, one and all. And thanks to our KCOG vibrant leaders, headed by the Dean, KCOG, Dr. Hema Diwakar, Chairman, KCOG, and today's convener, Dr. Muralidhar Pai, Vice Chairman, Dr. Basura Surgeon, Secretary, KCOG, Dr. Vidya Bhatt, for having such a wonderful webinar. Of course, today's guest speaker, Dr. Bhaskar Pai. Sir, it was a wonderful talk. In detail, very practical aspects were spoken of, supported by guidelines and recent advances on early pregnancy bleeding, which is a very common problem and which we deal day in and day out, sir. So I also thank our KSOGA office bearers, Chief Patron Dr. MG Hiremat, then Patron Dr. Nagraj, President KSOGA Dr. Vidya Tobe, Secretary General Dr. Ashipaldi, for this opportunity. And thanks all delegates for joining in. And Mr. Arun, thanks for arranging this Zoom platform. And thank you all, one and all, and good night. Thank you.
Thanks, Dr. Bhaskar. It is available on YouTube. I will share the link with you, and we will be sharing it also. It's already shared on the YouTube. So thanks again. We look forward to more interactions with you in future. Wish you all the best.
Thank you. Thank you very much.